Assalamu alaikum. Clinical day. The first scenario, Mr. Ahmed Jamal, 30 years old, came with complaint of abdominal pain. Please sit with him, take history, and examine the patient, address his all concerns. We are starting. If you are ready, we can start, Dr. Mahi and Dr. Ryan. Here you go.
Hello, I'm Dr. Ismail, Senior Health Officer.
Dr. Mahi, you can start, and Dr. Ryan. Hello?
I am ready,
Hello?
Dr. Mahi.
Hello, I'm Dr.
Dr.
Ismail.
Mahi, check your mic. We can't hear you at all. He's talking, but we cannot hear him. Dr. Mahi, check your mic, please.
Hello? I can hear you well, Doctor.
Okay, wait for him.
Why, Dr. Basim, I hear you.
We can't hear you still, Dr. Mahi. Check the mic. Okay, here you go, Dr. Mahi.
Hello, I'm Dr. Ismail, Senior House Officer of the Gut Doctor today. Am I talking to Mr. Ahmed and you are 30 years of age?
Yes, doctor.
Nice to meet you, Mr. Ahmed.
Nice to meet you, doctor.
What brought you to the hospital today, Mr. Ahmed? How we can help you?
Yes, doctor. Actually, over the past 1 week, I've been having severe tummy pain. It's really bothering me a lot.
I'm sorry for that, Mr. Ahmed. We hope we can help you today. Can you show me where is the site of this pain?
Yes, doctor. It's mainly in my right side of the tummy.
I'm sorry for that. If we score it from 0 to 10, how much you can give it?
I would say around 7 to 8.
I'm sorry for that. It is too much. You need the painkiller now?
I can manage, no worries.
Okay. What is the character of this pain, Mr. Ahmed? It is colic in nature or stabbing or dull aching or can you describe it?
I think dull aching, doctor.
For where it radiate?
What do you mean by radiate?
It can refer to anywhere in the side.
No, doctor. It's only in the right side.
Not to the right shoulder, not to the left side of the tummy?
No, doctor.
Okay. Apart from this pain, Mr. Ahmed, do you have any other symptom?
Like what, doctor?
Any throwing up, any feeling sick?
Yes, doctor, you are right. I thrown up 1 time over this past week.
I'm sorry for that. For this pain, Mr. Ahmed, what do you notice anything increase it or anything improve it? Like eating, like painkiller?
No, doctor, I didn't notice.
How it is started, Mr. Ahmed? Gradually or sudden?
Actually, suddenly, doctor.
Suddenly? And it is worsening with the time or improving or the same?
It's worsening a lot.
How it come, Mr. Ahmed? After attack of fever, after heavy meal, after?
No, doctor, I was sitting normally with my friends. I don't know. Suddenly, I started having the pain.
What about your his health in the past? What happened recently? Do you have any attack of infection or?
No, never. I am totally normal before.
Do you have any difficulty swallowing? Any change in the bowel habit?
No difficulty swallowing.
Any change in the bowel habit?
No, doctor.
Do you notice any swelling of your belly?
Yes, doctor, you are right. It's larger in size.
Larger in size. But there is no change in the bowel habit?
No, I didn't notice, honestly.
Do you have any changes in your skin? Do you notice any change in the color of your skin? Any abnormality?
And my skin, no.
In your eyes?
Yes, doctor, I noted my eyes are becoming yellow.
Yellow. Do you have itchy as well?
No,
Do you have any past medical history I should be aware of?
no,
Any hospital admission before?
no,
Any surgical operation?
no,
Any blood transfusion?
never.
Sorry, Mr. Ahmed, I wanted to ask you also some private questions. Do you have any piercing, any shearing of needle, any tattooing?
No, doctor.
I'm sorry to ask you this private question. Do you have any unsafe, unprotected sex?
No, doctor, I just have my wife.
Okay, Mr. Ahmed. Do you have any joint pain?
No,
Any skin rash?
no.
Any change in the bowel habit?
You asked me, doctor, before. No,
Yes, I'm sorry. Okay. Any raise of your body temperature?
no, doctor.
Any night sweats?
No,
Do you have any lumps or bumps in your body?
I didn't notice.
Do you notice any soreness on your mouth?
No, doctor.
Okay. Mr. Ahmed, do you drink alcohol?
Yes, doctor, occasionally.
How many units per week?
I think around 2 to 3 units.
I'm sorry to ask you, Mr. Ahmed, do you have any recreational drugs?
No, doctor.
Any travel history?
No,
Any travel history, Mr. Ahmed?
no, doctor.
Okay. Did you seek any medical advice before and you go to dental clinic or?
No,
Okay. Okay. Do you have any fast food from the street?
no.
Okay. May I examine you during I take history from you, Mr. Ahmed?
Yes, doctor, sure.
Okay. I wanted to see his hand. Is there any palmar erythema?
No,
Any debutolene contraction?
no,
Any changes in your nail?
no.
What about pulse?
Pulse is regular, 96 beats per minute.
There is any changes in the skin? Any bruising of the skin?
No,
Any thin skin?
no.
Okay. May I see also the face? I wanted to see there is any pallor?
Yes, pallor positive.
Anyone told you before that you have become pale more than before?
Yes, doctor, you are right.
Okay. Do you have any past family history of note?
Diabetes and hypertension in father.
There is no any blood disease before in the family?
I am not sure, doctor.
Okay. There is any characteristics of the face, thalassaemic face, or any changes
No.
in the
No
frontal bosom?
characteristic. No,
Okay. What about the parotid gland? Is there any enlargement of the parotid gland?
no, no enlargement.
Any lymph nodes in the supraclavicular area?
No lymph nodes.
Axillary area?
No,
I'm sorry to ask, there is any changes in the breast size?
no.
What about the hair, axillary hair? Is there?
Normal hair distribution.
Okay. Mr. Ali, I wanted to examine your tummy. Do you have any pain?
Yes, doctor, I have pain on the right side of my tummy.
Okay, I am
Please be
sorry.
gentle.
What?
Please be gentle, doctor.
Pigeon?
Gentle
What?
when you are
Be
touching.
gentle, be gentle.
Mr. Ali, I will be gentle while I'm examining you, but if you have pain, let me know, okay?
Okay,
I
doctor.
will do superficial palpation first. I will first to see the tummy, if there is any dilated veins in the skin, any
No
any
dilated
signs,
veins.
any raise of the GVB.
No.
There is a swelling of the tummy.
Yes, there is a
So
swelling with full flanks.
yes, yes. I will do superficial palpation first, then deep palpation
There is
to
tenderness.
check
Mhm.
in the right side. Yes.
There is
There
tender
is enlargement,
hepatomegaly.
tender hepatomegaly.
Tender
Okay.
hepatomegaly 4 centimeter below the costal margin.
Yes, yes. What about the spleen? Is there any splenomegaly?
No.
No splenomegaly?
No.
Okay. I will check for ascites, shifting dullness first.
Positive. Positive,
There
yes.
is?
Yes.
Hmm. Okay, then I will check for any edema lower limb also. There is any edema lower limb?
Mild bilateral pitting edema.
Hmm. I wanted to see if there is any hepatojugular reflux. Is there any hepatojugular reflux?
Not evident.
Okay, I wanted to auscultate the heart for any tricuspid regurg. Is there any tricuspid regurg? Any murmur?
No.
Any crackles in the back of the lung?
No.
Any sacral edema down?
No sacral edema.
Okay. Mr. Ali, um, i- you told me there is no any blood transfusion before, Mr. Ali?
No, doctor. I didn't get any blood
Any
transfusion.
any attacks of fever before?
Never.
Hmm. Okay. Do you have itching, Mr. Ali?
Doctor, you asked me before. No, I don't have.
You don't have itching?
No.
Carry on, Dr. Mahi.
What is your concern, Mr. Ali?
I am really worried, doctor. What's the reason for this tummy pain that I have? Can you treat it, please?
Actually, Mr. Ali, after I take history from you and I examine you, there is enlargement of your liver. There is this mostly there is soreness of your liver. May I ask you, sorry, Mr. Ali, may I ask you, do you get up by sleeping, from sleeping by night, coughing or looking for air?
No, doctor. I have mild shortness of breath, but I don't get up at night.
Okay, so Mr. Ali, now what after I examine you, I found that you have any soreness in your liver. There are many possibilities for this soreness of liver. I will run some investigations for you. Then I update you by the result of these investigations. One of these possibilities may be blood disease, some I wanted to say destruction of your red blood cells, so causing this problem. But I will update you by this. But what I will do now, I will admit you and I will run for you these investigations. Is that okay with you?
Yes, doctor. Doctor,
You
does it
admit
run in family? Does it
you
run in
ad-
family? I mean, my kids will be affected by this condition?
2 minutes left.
uh, I don't know, Mr. Ali. Until now, we did not reach the diagnosis.
Mhm.
But after investigations and reach the proper diagnosis, I will update you if this really runs in families or no. Because
Okay.
I asked you about family history, you told me only raise of blood sugar and only blood pressure only in the families before. But you told me there is no any family history of note for destruction of blood or anemia or hemolysis like this.
Yes, doctor, but I am worried about my kids. Maybe I have something that I will give to my kids.
I appreciate Mr. Ali, but first to reach the diagnosis for you, then we will look for your kids. Okay.
Okay, doctor, no problem.
Do you wanted to add anything in the history for me, Mr. Ali?
Yes, doctor. I think you
Well,
forgot to ask me, doctor. I have dark urine.
dark urine.
Yes.
Okay. Is this dark urine early in the morning or
Yes,
all
doctor,
the
you are
time?
right. You are right, early in the morning.
Early in the morning?
Yes, doctor.
Yes, so paroxysmal nocturnal hemoglobinuria, Mr. Ali. So mostly this enlargement of your liver is mostly due to blood clot. Maybe this is named as Budd-Chiari syndrome, thrombosis in the bloody channel going to your liver. But we will do for you investigations to confirm this diagnosis or exclude it. Okay?
Thank you, doctor.
Okay.
Okay, time is up. Unlucky,
Okay.
Dr. Mahi. Same topic 3 days back.
Really?
Same,
You put
really?
you Wallah, you did it,
Yeah.
Dr. Baxter? Okay, I
Yeah, he
didn't
did
know.
it with Dr. Mohammed Sarda, but you were absent. Okay, time is up. Examiner question.
Okay, can you present your case?
This 35 years old gentleman presented with a large liver and some decompensation of the liver functions. This mostly due
Okay.
to Budd-Chiari syndrome because this patient is hypercoagulable state due to paroxysmal nocturnal hemoglobinuria.
Okay. What are your differentials?
Differential viral hepatitis and chronic hemolytic anemia can be
Okay.
also viral hepatitis, inflammation of يعني granuloma of the liver like this, infiltrative disease. Heart failure also is a differential diagnosis for this congested liver, tender. This
Okay. What are your investigations?
investigations, I will do bedside test for this patient, ultrasound, yes, ultrasound Doppler for the liver. And I will do also a liver function test, prothrombin time, coagulation profile, total and direct bilirubin. I will do CBC also to see how much hemoglobin and haptoglobin, signs of hemolysis like this. We will do this dark urine also. We wanted to take urine sample and expose it to the air, possibly it turned dark. Is this characteristic issue for this issue, paroxysmal nocturnal hemoglobinuria?
Anything else?
Other general investigations also for this patient.
Any specific investigation you want to do?
Kidney function.
Hmm?
If we cannot diagnose him by ultrasound, we can do also angiography.
For PNH, for paroxysmal nocturnal hemoglobinuria. Any specific test you want to do?
I'm not sure.
Okay, no problem. How are you going to manage this patient?
This patient will be managed by multidisciplinary team, including a blood doctor, hematologist, and hepatologist. So this patient, non-pharmacological patient education counseling and pharmacological medication, we will give him anticoagulant, and if failed, we will give thrombolytic therapy. Then if we will assess the liver function, how much, if failed, or we will do the portosystemic shunt. If failed, so we will go to liver transplantation. For treatment with the paroxysmal nocturnal hemoglobinuria also, this patient, it has a specific treatment, but I cannot remember it now.
Okay, no problem. Anything else you want to add?
No.
Okay, thank you. Dr. Basim, anything from your side? I am done.
Yes, I have question. How you say viral hepatitis in this patient as a differential? What's your rationale? Patient present in 1 week only.
I think Dr. Basim, hepatitis A can present acutely.
I'm asking.
Well, you're asking him? Oh, okay. Sorry.
Yes, I want to test his knowledge. How you
Okay,
can think
sorry.
about hepatitis in this patient? No worries.
Okay, sorry.
Dr.
Yes, I ask about travel history for
Yeah, no.
hepatitis.
I'm asking
But
why you give
hepatitis
as a
B.
differential. Yeah, give me answer this question.
يعني justify your differential. أيوة.
ايوه انت قصدك يعني incubation
Yes.
period بتبقى longer than 1
Exactly,
week.
it will be chronic. So my question, Doctor, already Dr. Ryan answered it. Could think about hepatitis A or what other viral can present as acute.
A,
hepatitis E او
Yes,
D.
A and E. Yeah, A and E. Okay, and how the route of infection in hepatitis A?
orophycal route. Yes.
Exactly, and you rule it out by a travel history and also the eating history or food history. Okay. I want to ask more, but okay, we already discussed this topic, I think, 2 days back with Dr. Muhammad, the same case, but with another pathology. It was SLE and antiphospholipid antibodies positive syndrome, and patient also present with the same. I'm wondering how Dr. Mohi missed the case, and it was the same presentation: acute onset abdominal pain with jaundice, ascites. Okay, let's hear the comment from Mr. Ryan, then I will comment.
ايوه عشان انا بس نسيت موضوع ووتر وورك ديت يعني.
In English, Dr. Mohi, please.
I
Yes.
forget this يعني you know the history, we should يعني train ourselves too much for
Exactly. Yeah.
this
This
in
will be yes.
no any clue يعني شوف
No
يعني
worries. No
urine
worries.
water
It's
work يعني حاجة
yes.
ذكية.
Yes. It will be solved with practice.
Usually I
So
wanted to start. Yes.
no worry. No worry.
I tried to
Let's
look since she said to me right upper quadrant pain and jaundice. خلاص this is liver, but what is the cause for this? يعني pain is not only thrombosis. Pain may be due to enlarged liver, يعني heaviness on the capsule and like. But
so
what is the cause?
the onset
Heart
will
failure is
guide
the
you.
cause.
The onset will guide you. Let's hear Dr. Ryan comment, then I will comment. Okay. Go ahead, Dr. Ryan.
Okay, sir.
Actually, Dr. Mohi, I think you took a very good history and targeted to look for the reasons for such condition, but you were a little bit not organized, and that's why you missed the urine part. You missed a couple of questions. I think you have to search also for any reasons to cause. So first of all, it's a sudden onset, although it can be subacute. Sometimes it can be few weeks, like 2 to 3 weeks. So don't think always sudden onset 1 week. But this is a hint that it's sudden onset 1 week and worsening, and ascites. Ascites in 1 week, there is something. Always think of bad Chiari. Yani ascites will usually take time with signs of stigmata of chronic liver disease. But this patient in 1 week developing ascites without stigmata of chronic liver disease, yani put blood Chiari number 1. Then you'll search for the causes. You have to look for all the causes of thrombophilia. يعني hereditary thrombophilia screen, protein C, protein S. This will most likely you will get from the family history. But also you have to ask about any history, personal history of clot or family history of clot. Important. And also you rule out other causes. So I think you asked about soreness in the mouth. I'm not sure if you asked about soreness in the private area. For Bahjat disease, very important. For what is it? This polycythemia vera, you have to ask headache, dizziness. This although less likely in such a young age, but you have to exclude. Yeah, and paroxysmal nocturnal hemoglobinuria, the dark urine early in the morning, which you missed because I think you were not organized in your history. Once you analyze your main complaint, I believe, and I think after analyzing the main complaint, you tried to look for differentials that are in your mind, which was good. I don't say it's bad. It's actually good. But then after you rule out your differentials, or you ask about your questions or whatever you want to exclude, do systemic review head to toe. At some point you will get something. If you did head to toe, you will get the urine and you will get the case earlier. Yeah, and I think that's mainly it. You asked all the risky behaviors, which was excellent. You asked the travel history. In the examination, don't forget the vital signs initially. I think you did not ask initially about the vital signs. Then I believe that you repeated a lot of questions in the history, maybe because you were suspecting something to be positive, then you were shocked why it's not positive. You keep repeating the same question. So if the candidate told you no, then they know it's most likely no. Unless if you are sure that there is something wrong, you can double check the question again. But you asked many questions multiple times. And also when I told you no splenomegaly, you told me no splenomegaly, like you are wondering why no splenomegaly. I think you are putting thalassemia or something of the hemolytic anemias in your mind. Okay.
It was the same.
Yeah. Okay.
Anemia and jaundice take hemolytic anemia. يعني this is
صحيح. You are right, but not necessarily to be يعني to feel splenomegaly. Sometimes you might not. By the way, there are cases.
There is anemia here, significant anemia.
Yes, there is pallor, there is jaundice in this patient.
Jaundice due to liver thrombosis, but anemia.
Anemia due to the disease itself.
Yes, he has hemolytic anemia, so he has hemolysis leading to jaundice, and he has this pallor from the anemia.
Has no spleen.
Has no, not necessarily to have a spleen, to my knowledge. I don't know if you, Dr. Basim, you want to correct me, but to my knowledge, I don't know if they have a spleen.
PNH extra or intravascular hemolysis.
Intravascular, so they will not have a spleen. Yes. That's why they have the dark urine, because intravascular. Okay. In the examination, it was good. You checked for stigmata of chronic liver disease, although it's less likely in such an acute case, but it's good to check for them. I think you missed the hepatic tremor, the flapping tremor. In the eyes, you asked me for the pallor, but you did not check for the jaundice. You only asked in the history. Make sure you check in the examination.
I look at the face and I check in eyes for the jaundice and anemia.
When you asked me, you said pallor only. You did not mention, but anyways, you will see it in the examination. No worries. Okay, parotid enlargement you check. Mouth soreness was excellent, and the abdomen. I think the rest of the examination was good. When I asked you to present your finding, you told patient presented with hepatomegaly. So I don't think this is a presentation. So he presented with abdominal pain. No need to mention all the history. You can mention main points in your history, but you can mention the patient presentation, the patient complaint, like briefly, because already they heard your history. I believe that you can mention just few words about the patient main complaint presented with sudden onset abdominal pain with abdominal distension or swelling with dark urine. On examination, I could find this and this. The top of my differential is Budd-Chiari syndrome due to an underlying paroxysmal nocturnal hemoglobinuria. And then you mention the rest of your differential. Okay. Then in the investigations, I think you mentioned. You want to say anything?
You mean when the examiner asked me present your finding, I will tell him the symptoms first, then I go to the examination. Okay.
Yes,
okay. Because I'm become frustrated.
No need to become frustrated. Why? Actually, you are doing good. but I think you need to be systematic a little bit. You are doing very excellent targeted history taking questions actually. That is really excellent.
Yes,
But
yes.
after you
Continue.
doing this, I think you have to do systemic review head to toe, so that if you missed anything, you can get it. And it was a good question that you asked the patient. Anything else that you would like to add? When you did not get the case, and if you ask this question, you might get a hint. Maybe ask this question earlier before your examination. I think that would help a lot. Okay, and then in the investigations, I think you mentioned most of the investigations. Mainly in so for Bad Chiari, as you said, Doppler ultrasound of the abdomen. Sometimes they also consider actually ascitic drain because of this sudden onset of ascites. Ascitic drain and send ascites for cytology and culture, and also for SAG, serum albumin serum albumin gradient. I forgot it, the SAG. Okay, and for PNH, flow cytometry to
Serum
detect
albumin acidic gradient.
ايوه serum albumin acidic gradient. شكرا دكتور باس. For paroxysmal nocturnal hemoglobinuria, flow cytometry of the blood to detect CD59, CD55. Okay, this is the main diagnostic test. By the way, this flow cytometry is very important in two cases: PNH and CLL, chronic lymphocytic leukemia. Okay, is it chronic lymphocytic? أيوة, chronic lymphocytic leukemia. This flow cytometry is the main investigation in these conditions. Okay. I think that's mainly it. Okay. And the management plan, as you said, active disease education and counseling, hepatology or GI and hematology involvement. Also, in this case, you will give anticoagulation. For the PNH, treat the underlying cause PNH. We can replace blood products if they have, because they are at risk of getting pancytopenia. So they can have anemia, and you will need to, for example, transfuse according to the results. This is one thing. Another thing is the main treatment is eculizumab. That is monoclonal antibody against C5. Okay. The last resort is stem cell transplantation. Also, when you ask about the dark urine, don't forget to rule out infection. So ask about burning, micturition, changing the frequency, frothiness, and this stuff. These are my comments.
Yeah, perfect. Thank you, Dr. Ryan. Very nice case. And it's another training for Dr. Mohi about this topic. Within week, you have the same topic with two different causes. I guess you will learn more about this topic today. And the most important question, I remind you the last time, you have to ask it, but again, you missed it today, which is,
Yes.
did you have this attack before? Any previous abdominal pain? You missed this question.
والله
Why?
كانت على بالي والله، بس راحت
No,
من
no,
دماغي بس
no
عليها.
worries, no worries, Dr. Mahi. I'm not saying to blame you. I'm just teaching you how to do it in the proper way. So this question will help you that you have something very acute, first time and acute. Okay, but remember it. Always remember it. Onset course duration. You remember OCD. Onset course duration. Onset course duration. For the pain, you can add the severity and the timing and the position and what increase, what improve. This question will help you. In this scenario, the onset will help you to go to direct you to the acute causes of abdominal pain. Let's think together now, Dr. Mahi. What the causes, or what are the causes of abdominal pain, acute abdominal pain in the right hypochondrial area?
Liver, yes, liver allergic.
Perfect.
Maybe yes, liver gallbladder stone, like this, ascending
Perfect.
cholangitis.
Exactly. So you will not go through the causes of chronic liver disease. I agree to ask about them. You have, since you have hepatic problem, you have to screen the HIV, the hepatitis, blood transfusion, persec, tattooing. Yes, but it's not the main cause here. You have something acute. How this patient presented in the acute onset presentation like this. So it might be either acute cholecystitis or acute, as you said, viral hepatitis, or our patient here, Budd-Chiari syndrome, thrombosis, or you can say liver abscess. Agree? It's
Yes,
not
yes.
common in the exam, but it's like this or hydatid cyst rupture, but it will not be chronic hepatitis. Chronic hepatitis will be in the chronic term. Patient will have on and off jaundice and failure, decompensation, then compensation, treatment, admission. But this patient present in 1 week, so rule out the chronic hepatitis causes. But you have, of course, you have to screen about them at the end after getting the possible cause. But because you didn't ask about the onset clearly, you didn't know that the case might be again as bad carry as a thrombosis, I mean.
Actually,
So
Dr.
this,
Basim, he asked about the onset, but I don't know why he
yes,
just
he
skipped
went
it.
through the chronic. He didn't give attention to this.
Yes, yes.
Yeah, so that's why he became confused and asked about the causes of chronic hepatitis or chronic liver disease, which is not the case here. The case here is related to acute cause of hepatitis or something in the liver. So if you want to ask here, you can ask about cholecystitis, but this is not the case again. This male patient, you ask about the male related. Yes, I agree. This question will rule out acute cholecystitis. The other causes, as I said, liver abscess or infection. Travel history also will give you a clue if you have travel history. If not, you have to suspect bad carry. And once you suspect bad carry, you can screen the causes of thrombophilia. In this patient, BNH, paroxysmal nocturnal hemoglobinuria, and antiphospholipid at the previous case, and OCB in female, and some disease, inherited disease like protein C, protein S deficiency, factor Leiden. So you will know from the family history. And when you suspect family history of some condition, you have to specify it. I mean, in this scenario, if you suspect clotting, so you will say any history of clot in the family. It's very important question, and it might tell you yes, or she might tell you yes. Isn't Dr. Ryan supposed to be positive?
No, I will not mention it, but it's an important question. I did not prepare it like this time,
Mhm.
but it's an important question to ask. Any previous personal history of clot or family history of clot?
Perfect. So this question will help you. So it will guide you to the target. Any history of blood clots or any history of blood clot in the family. Okay, Dr. Mahi. This is my comment. Dr. Ryan, mashallah, give you a lot of good comments. I mean, positive comments. So you can correct them. Like a repeating question. So don't say the question, try to push here toward this diagnosis. It makes sense like you are pushing to the diagnosis. Splenomegaly isn't, be sure is it about splenomegaly? No, it's not. So don't ask it again. You ask about jaundice, I think 3 times or something else, and don't do combined question. Don't ask about 3 things together: bowel habit and jaundice and tummy pain. No, ask one by one. This is the way how to ask. The last comment about the name, you mentioned Ali, and again yeah, I said the last time, if you are not sure about the patient name, forget it at all. Just say sir. Hello, sir. How are you? And but you have to confirm at the beginning. You are Mr. Ahmed Jamal. I'm intended intentionally write 2 names because once you go inside, you have to confirm the patient name by 2 names, not only by name. We used to say you are Mr. Ahmed 30 years. No, it's not the way to confirm the patient data. You have to say patient, if they have 3 names, you can mention the 3 names. The first time only. You are Mr. Ahmed Jamal Omar, for example. Yes, doctor. You are 30 years old. Yes, doctor. Then go ahead. Whenever you are talking with him next times, you can say sir, sir. If she is female, you can say madam. I'm repeating this because I know whenever you go inside the station, you will forget the patient name totally. It happened with me, by the way. And I was looking at the paper, and it gave impression to the examiner that you are not concentrated.
Also, I think Dr. Basim, he did not tell me that I will take history and examine you. You
Yeah.
just told me how can
I
I
am the
help
doctor
you?
in the gut. I am
Yes.
the doctor, yeah, and what brought you? Okay. The other thing also the position. I didn't write you are doctor in the gut or whatsoever. So don't mention something not mentioned in the scenario. Yes, they will write for you and you will follow it. But I am trying to make you ready for any scenario and any position and any clinic. The best thing to say, I am one of the doctors here. I am repeating this advice because I am 100% sure whenever you go inside the station, you will forget your name, you will forget the clinic, you will forget the position. So the best way to mention I am one of the doctors here. You are Mrs. X and you are 50 years old, and carry on either by sir or madam. Okay, I think this is my comment. And this organization again, yeah, I commented previously. Try to listen to the video. I put it down. How to do systemic review from head to toe in organized way. You didn't reach the diagnosis, or you reached the diagnosis and you want to do systemic review, just to get the positive finding. Follow the system review I did in the video. Follow it. I wrote it in the chat box. In 2 minutes, you can finish the whole systems. Any positive finding and the patient will help you with, she will say or he will say it if you just touch this point. For example, any urine change, she will say it definitely because you ask her, did you or you want me to tell you didn't you want to tell me something? She mentioned you about the urine change. But if you ask the urine change, of course she will tell you, yes, I have a change in my water work or I have dark urine, as she said. So if you touch every system, you might catch some finding, and you have to do it in the system review. This is the way how to catch the positive finding from the system review. Okay, clear, Dr. Mahi?
Clear, sir. Clear.
Yes, okay. Dr. Mahi, can you post the scenario for Dr. Ryan? And I will try to read the comments quickly because I read a lot of comments, which is really a nice one.
Dr. Basu, can I have some comment?
Yeah, sure, Dr. Azhar, of course.
Uh, as Dr. Rayan, she explained very well. Just I want to give you some hint how to memorize this paroxysmal nocturnal hematuria. We will remember only word path, PATH. Path means pancytopenia, aplastic anemia, T means thrombosis, H means hemolysis. If we will memorize this, according to this, we will give our treatment. Pancytopenia, PA, pancytopenia and aplastic anemia, the treatment will be according to the situation, blood transfusion, or we can give oral tablets. T for thrombosis, we will give antithrombotic agent. And for hemolysis, during hemolysis, we can give corticosteroid. These, if we will memorize these four-word PATH, we can memorize the signs and symptoms of PNH, and then we can give the treatment according to this. As Dr. Rayan told, that eculizumab, this is a definitive treatment against the CD55 and 59, and finally we can do the stem cell transplant. It will be easy for us how to memorize these in the exam.
Yes. Yeah, thank you, Dr. Azhar. Nice way. If you can write this approach in the chat box or the WhatsApp group, it will be much beneficial.
Oh, oh,
Yeah, thank you so much.
thank you.
Uh, let's go to the next scenario. You wrote it, Dr. Mahi? Still?
Yes, I'm writing, sir.
Okay. I
I'm
will read
writing.
no problem, no worries. I will start from the last question. Dr. Phoebe asked, what are the differential for this case? I will start, Dr. Phoebe, with acute hepatitis. It's much common than. Yes, I agree with the Dr. Manhal mentioned. Yes, of course. Yeah, she wrote it up. Okay, acute hepatitis, exactly. Then the other differential, rupture headache cyst, liver abscess, but Chiari. But please add before them acute cholecystitis. It's another common presentation, more common than hepatitis cyst and liver abscess. And but Chiari, as spaces wise, it's common. But Chiari, you should roll it out as acute cause of right hypochondrial pain, and of course you will will have jaundice and ascites. You have to find this triad of presentation. Clear? Good question about the differential. Let's go to the, yes, I wrote eculizumab just to remember it. Eculizumab, it's one of the biological therapy against the CD55 and 59, and it will not be seen in the other medicine again. I guess so. Eculizumab, try to remember it in the PNH. Okay, the scenario here, Mr. Muhammad or Muhannad Ali, 30 years old with easy bruising, his lab, hemoglobin 9, patient BTT and BT are normal. Get ready, Dr. Ryan. I will read comment until you be ready, okay?
Dr. Basam.
Yes.
Dr. Basam, with the differentials, we can add at the end congestive cardiac failure and constrictive pericarditis. Can we add or not?
Infective endocarditis,
Under
uh,
hepatomegaly.
but as acute.
So, can we add or should not we add? What is
I think you will have other finding like the stigmata of infective endocarditis. I don't think it.
at the end, because if the patient is already having some symptoms of cardiac problem, he can present any time with the acute problem, with the chronic, acute on chronic, congestive cardiac
Yeah,
failure.
it will be acute, as you said, acute and on top of chronic. But in this patient, no chronic at all. It's just presented once.
I think acute can be, for example, anemic heart failure, acute anemic heart failure from the underlying anemia. So can be a differential. After, as Dr. Basim said, acute hepatitis, acute cholecystitis, cholangitis, acute
He,
heart failure.
he mean acute congestive heart failure, right? Not infective
Acute
endocarditis.
congestive heart failure. It should be.
I
think
mean
it
heart
should
failure.
be.
I mean heart failure, not no.
Okay, yeah.
It's 1 week history, so I don't think. I don't know.
The heart
And there is
failure
no
also,
fever, so
yeah, the heart failure will be long term, not acute. It's chronic. I guess so.
Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa
She
barakatuh.
also she mentioned the pain was sudden onset.
Exactly.
Since sudden onset, that's it will narrow the differential
Yes.
to thromboembolic event like that or ischemic also.
Yes, exactly.
It will limit the differential, I think.
Yeah, I agree. Someone wrote paracetamol toxicity. Yes, of course, it could be, but supposed to be any suicidal attempt or any psychological problem in the scenario. Okay.
I have a question.
Yes, go.
The candidate يعني said after told after 6 minutes he will examine the patient while asking for his history from here. Is this logic for acceptable in the exam, or better to finish the history then going for the and
Yeah,
if remaining can go back to history?
good question, and I really appreciate this question. Yes, it's of course it's up to you. Whatever you want to do in the exam. Whatever you think you have to run to examine the patient. Why? Sometimes you will spend a lot of time in the history taking and you will forget yourself with the time, and suddenly you will find 2 minutes left and you will not do any examination and you will miss 8 marks in the examination for in both skills, identify, finding, and physical examination. So please, if you finish the history well and you get the most probable cause or the diagnosis, you can run to the investigation. Yes, 6 minutes, okay, and you can ask later on some question. But I believe Dr. Mohi here was disorganized and he missed a lot of social, occupational. Still, he should ask these questions, and he didn't do so. I guess he was not organized enough. That's why he went to the examination. But I believe if he remembered the social and occupational, he will ask before examining the patient. I guess he was
Because
forgetting this point.
I get blocked. I don't have any clue
Yes,
from
I
the.
know. Believe me, Dr. Mohi, this session and the practice make you more professional,
I know.
and
So
you know. Yeah, go ahead. Hello.
Yes, yes, sir.
Okay, so you will know when to ask and what to ask if you are feeling blocked, mentally blocked.
I finish the analysis of the complaint and GIT and the differential diagnosis, what I know and my knowledge reach to. Then I ask
Perfect.
about medical
Okay.
history, medication history, family history, examination. I wanted to ask you, Mr. Basim, for if I did not catch the diagnosis, I will lose the station at all, or
No,
I will
no,
take
no,
some
no, no. We have to correct this idea and this thought inside all of us. If you do approach properly and you mentioned that this differential, the diagnosis in the second differential, you can get full mark in the second differential. They will minus you whenever you didn't mention the diagnosis, maybe the second differential. So if you put it number three or you didn't put it, they might minus you. But believe me, whenever you are doing it in a proper way, you will catch the diagnosis. At least you will put it in the second differential. So
So
no worry
how
about
much
that.
you can give me if you are the examiner today? How much you will
They,
give me for
they
complaint?
can give in this scenario before
Yes.
you get the clue or after the clue. Before the
I
clue,
ask
of
here.
course, you can get half of the mark. Like 28, you might take 14. Okay,
But
but
I preserve the welfare of the patient. I do clinical examination
it's
and
not.
I present the
This is not a matter of welfare and the
positive finding.
concern only. No, yes, there is
The-
identify finding. There is other five skills you have to fulfill the criteria of five skills apart from welfare and concern. The physical examination, the identify the finding, clinical judgment, differential diagnosis, I mentioned clinical communication. These parts or these skills, it might be harmed even if you preserve the welfare and concern, you might get very bad mark. Okay, so no, don't worry about this. After
Dr. Mohi, I want to just add one comment. If you cannot read the diagnosis, you can have a one question, one statement at the end that Mr. Ahmed, you have abdominal pain from 1 week and you have fla fla fla. On the examination, I have found that you have enlargement of the liver, 4 fingers. Is that all, or you want to anything? Is that all? Or you want to add anything? Maybe the surrogate is very good. He can give you like Dr. Rayan, she gives you this clue. So at the end, you can ask this the statement. Maybe he will give you the clue. If he will give you the clue, then you can have 28 marks.
exactly as
Okay.
Dr. Azhar said, yes. But again, no worries. As long as you are practicing the cases, you will know a lot of cases and all cases recurrent. If you notice the all recalls, the cases comes here and there from the center to other center, the same case, the same presentation. And once you practice one of them and once, you will never forget it. So it's a matter of practice. Again, practice and practice and practice. That's why we are maintaining these
Okay.
sessions daily. Anyone has case to present or he want to test himself in another case, he can present it or he can receive it as a known case. Or if he has weakness in some topics, he can present the case itself. He can make it as a surrogate and he will be perfect in the presentation. Of course, whenever you practice the case as a surrogate, you will know it because you practice it and you give him the positive finding, the positive examination, the positive history. So whenever it will come to you, you will do it the same. Please, if you feel yourself weak in certain topics, do it and try to make for yourself a schedule for the cases common in basis and do it in a regular manner in regular sessions, either with partner or with me, as you like. Okay. Okay. Let's start the second scenario. Dr. Ryan, ready?
Yes.
Dr. Mahi,
Okay.
here you go.
Hello, my name is Dr. Ahmed. I'm one of the doctors in the clinic today. May I confirm that you're Mr. Muhammad Ali, 30 years old?
Yes, I am.
Nice to meet you, Mr. Muhammad. I'm here to ask you some questions about your health condition, to examine you and answer your concerns. Is it okay with you?
Yes, yes.
Can you please tell me how can I help you today?
Actually, doctor, I have some bruising in my skin. This for long time. I neglected before, but recently become annoying, and my friend is all the time saying, "What this? What this?" And I become ashamed for this issue. So I came to you today to may you help me.
I'm sorry for your suffering, Mr. Muhammad. I'll try my best to help you. Can you please tell me when did you start noticing this bruising?
I noticed it from long time, really. But recently, I was playing football with my colleagues, and I found some trauma. So this bleeding become significant
Okay, where is the bruising exactly?
in the skin of my limbs, mainly in the lower limb.
Mm-hmm. Okay, and you had it. Can you please tell me, like, long time? You mean years or a young age?
Yes,
What do you mean
yes,
exactly by long
years,
time?
years, yes,
For
for
years.
long
Okay,
years.
okay. And you told me you had a trauma when you're playing football, isn't it? Did you injure yourself?
Yes, and sometimes also, doctor, without trauma, I notice some areas of the skin in my tummy. There is also blood below the skin.
Mm-hmm. Okay. Any bruising anywhere else apart from your tummy and your legs?
Actually, any part of my skin is liable for this bruising.
Mm-hmm. Okay. And uh, apart from this, do you have any bleeding from anywhere else?
Yes, sometimes it comes from my mouth, from my back passage, like
Mm-hmm.
this.
Is it fresh blood?
Yes,
Okay. From your mouth, you mean you're coughing up blood, or when you're brushing your teeth? What do you mean exactly?
yes, brushing my teeth. Yes,
Mm-hmm. Okay.
and
Apart from this,
yes, I vomit one time also, and it was dark. I don't know. This is blood or due to the food itself.
you vomit, you told me, or what?
Mm. Yes, one time.
Okay.
Yes,
When was this?
last month.
Mm-hmm. Have you had any recurrent vomiting before, like this, similar, recurrent
No,
throwing
no,
up of
no,
blood?
no,
No. Okay.
no, no. It was once only.
Mm-hmm. Any bleeding from your nose?
No,
Any coughing of blood?
no, no.
Okay. Can you tell me more about your bowel habits? You told me that you are having blood as well in the stool, yes?
Yes,
How much is the amount?
it was infrequent attacks, doctor. But my bowel habit is okay. No problem.
No loose motion or hard stool, yes?
No, 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 no,
Okay. And is the amount large in the stool? The amount of blood?
no, no, no. Few.
Okay. I'm sorry to ask you, is it mixed with the stool or even without stool you're getting blood?
Sometimes with stool and sometimes without stool.
Mm-hmm. Okay. Any pain when you are passing stool?
No, no, no,
Any dark stool, dark color?
no, no, no,
Any blood in your water work?
no,
Mm-hmm. Okay. Any blood thinner medications that you are taking?
no. I'm not on any medication.
Any over-the-counter or herbal medications that you're taking?
Sometimes I feel headache and I take for this painkiller,
Which painkiller are you taking?
paracetamol only.
Mm-hmm. Okay. Do you have any past medical history I should be aware of?
No, I don't have past history.
Okay. Any history of a kidney problem or bleeding problem?
No, no,
Any surgeries or procedures that you have done before? Any family history of a blood disorder?
no.
Any family history of note?
Yes, my mom died suddenly, but I don't know why. I was young at that time. And they told me, but I'm not sure that bleeding inside her brain.
I'm sorry for your loss. Okay. Can you tell me more about the headache that you have? For how long are you
Yes,
having
I
this
have
headache?
headache, doctor. Yes, sometimes I have headache. Maybe this because of my friends. So, why this skin and laughing at me? I become ashamed and I go to my home. I feel some tension and I feel headache at that time. Maybe this is the cause. I'm not sure.
Can you tell me more about this headache? Is it where is it exactly? Is it all around the head, or where is that exactly?
Yes,
Mhm.
it is all over the head. Yes.
Do you feel anything increasing this headache, like coughing, sneezing, bending forward?
I'm not sure, doctor.
Is it more early in the morning?
No, no, no.
Do you feel it going to your neck area or any neck stiffness associated with it?
No, no. It is infrequent and it was mild headache, doctor. Leave it.
Oh, okay, okay. Apart
I
from
came
this,
for this. Yes, yes.
okay. Apart from this, do you have any dizziness or dizziness on standing from sitting position?
No, no, no. Maybe this because of blood loss or anything. I feel some weakness. Yes, maybe this is, you are right. My colleagues told me that you are pale other than before. So maybe this is the cause of dizziness. Yes.
Okay. Apart from this, have you ever lost consciousness?
No, no, no,
Any weakness in any part of the body?
no,
Any problem with sensation? I mean your feeling?
no, no, no. Sensation is okay.
Any mood issues, mood problems?
My mood is okay.
Any fits that you had before?
No, 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 no,
Any sleeping problem?
no, no, no,
Okay. Do you have any raised body temperature?
no,
Any sweating?
no.
Any lumps or bumps anywhere in the body?
I don't have lumps and bumps, but I don't know why my skin is like this, doctor. It looks loose skin like this, weak skin.
Okay.
Maybe thin skin,
Maybe what? Maybe what?
or I don't know why my skin is not like other people. My skin is not like other people. Yeah, I think it is more thin than people.
And do you feel that you are taller than other people as well?
You're what?
Taller, tall. Do you feel that you are tall?
Tall?
Mm-hmm.
No, no, no. I stand in front of you. I'm not tall. I'm not tall.
Okay, okay, okay. Okay. Apart from this, do you have any changes in weight?
Weight, my weight is okay.
Any change in appetite?
Appetite is okay.
Any tiredness?
I feel tired, but maybe it's because I am pale.
Anyone commented that you have, or did you notice any yellowing of your eyeballs?
No, 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 no.
Okay. You told me no coughing of blood. Is it right?
Yes, no, no cough.
Okay. Any shortness of breath?
No.
Any chest pain?
Yes, I have chest pain, doctor. Yes.
Can you tell me?
More in the, yes, below my left breast. I have this pain and it radiates to the left shoulder. And it came when my heart became racing during walking, climbing stairs. I feel this pain really. It is sharp pain, really.
Okay. Is it associated with any sweating, any throwing
No,
up?
no, 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 no,
Okay.
no, no, no.
Is it the first time to have this pain?
No, it's been for a long time, particularly when I run and play football.
When what? Sorry, I didn't hear you.
Playing football with my colleagues.
Okay. Do you feel pain when you touch your chest?
No, 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 no.
Okay. Any
It is
awareness of
from inside.
Any awareness of heartbeat?
No.
Any tummy pain or tummy bloating?
No.
Any heartburn?
No.
Okay. Any problem with your water work?
No.
Burning or frothiness?
No.
Any recent travel?
No.
Okay. Can I ask you some personal questions?
Yes, doctor.
Do you smoke?
Yes, like or people, I 5 cigarettes per day like this.
I advise you to stop smoking as it's dangerous to your life, and if you need help, we can refer you to smoking cessation clinic. Is it okay with you?
Okay, doctor. Thank you.
Do you take any alcohol?
No.
Do you have any partner?
No.
Okay. No recent travel, you told me, yes?
Any what?
Travel. I just want to make sure.
No, I'm not traveling.
Okay. Some personal questions, please. Any tattooing or piercing before?
What?
Tattooing or piercing?
No.
Any history of blood transfusion?
No.
Okay. What do you do for a living?
I am secretary, doctor.
And how is this affecting your life?
It affects my daily activity, and when I go for break with my colleagues and play football, this bleeding from my skin is annoying me too much. Really.
I'm sorry for your suffering. Okay. Just a few questions. Do you have any joint pain?
Yes, no joint pain, but I feel my joint is loose, also like my skin.
Okay. And any skin rash or skin changes apart from thinning of the skin?
I told you my skin is loose, so it look folding like this. My skin is more than my body.
Okay, no problem. Can I examine you?
Yes, doctor.
Vital signs of the patient?
Vital signs are okay.
Okay, I want to check the hands. Long hands, elongated, thin skin.
No, yes, loose skin. There is loose
Loose
skin.
skin. Okay, any changes in the hands, any in the joints, any swelling, any changes in the nails?
No swelling, but the joint is hypermobile. You can
Hypermobile?
do the
2
joint.
minutes left.
Okay,
Yes.
I want to do some sign and wrist sign. Any positive or no?
No.
Okay, I want to check the pulse. Synchronized.
Yes.
Okay, I want to check eyes, any conjunctival pallor, scleral icterus.
No, but the colors of conjunctiva is the color of sclera is not. It is blue.
Blue?
Yes.
Okay. Okay, any mouth sores?
No.
Okay. In the heart, any murmurs?
There is click only on the apex of the heart.
Click. Okay. Any basal crepitations?
No.
In the abdomen, any tenderness, organomegaly, palatable kidneys, auscultation?
No.
And the legs, any swelling?
No.
Okay, I will just examine the rash, the bruising. Okay.
Yes. While you are seeing you notice something like cigarette burn on the skin.
Cigarette burn?
Yes, look like cigarette burn on the skin. Scar due to the trauma. While I am playing football, there is trauma to the skin. Then it healed by this look like burn. Cigarette burn.
Okay. Okay, Mr. Muhammad, what is your concern?
Why my skin is like this, doctor? It is curable. Can you give me any medication or any surgery to correct this problem for me?
I highly appreciate your concerns, Mr. Muhammad. Actually, I have a few possibilities in mind. Of them could be a problem with your collagen. that is a protein that is responsible for the skin elasticity and your bones. And so we need to run some blood tests, and we need to do some scans, and we will involve a group of doctors, including the joint doctor, specialized staff nurse, and we will do for you, and we will involve the blood doctor as well. Do you have any more concerns for me?
No, I may ask you, Doctora, why they told me my mom died from bleeding inside her brain? Is it related to my condition? Will I die like my mom?
I highly appreciate your concern, Mr. Muhammad. Some of this condition runs in family, so it might be a condition that is that your mother had.
Doctor? What this condition, Doctor?
There are few possibilities. One of them is called Ehlers-Danlos syndrome. Don't bother yourself with the medical term. This is a problem in the collagen production. There are other possibilities as well. And I want to ask you one more question, Mr. Muhammad. Do you drive?
Yes, I'm driving.
So I advise you to stop driving right now because you're having this headache and dizziness until we get to the bottom of this condition. Is it okay with you?
Okay, thank you.
Thank you.
Okay, examiner, question.
What is diagnosis and differential diagnosis for this case, Doctor?
Could be Ehlers-Danlos syndrome, osteogenesis imperfecta, pseudoxanthoma elasticum, other conditions like Marfan, other connective tissue disease, Marfan, homocystinuria. But against that, there are no typical features.
So, what is your proper diagnosis? Evidence by what?
Sorry?
What is your proper diagnosis? Ehlers-Danlos or pseudoxanthoma elasticum? Or
والله I am not sure, yeah, doctor. But I have these possibilities. I'm not sure what is the exact one.
What are the positive findings in your case?
Bleeding tendency, easy bruising, thinning of the skin, family history of brain bleed. She also has murmur on examination.
No murmur in examination.
Click in the examination.
Yes, what is this click?
Most likely due to mitral valve prolapse.
Yes, it is associated with this condition, yes. What else for this case?
What do you mean, what else?
Joint hypermobility, so?
Yes, joint hypermobility, yes.
Yes, so components of this case, loose skin, easy bruising, hypermobile joints. With bleeding from GIT. So patient has also dysphagia, but you did not ask. No problem. And loose sclera. So this case is Ehlers-Danlos syndrome. So how you will treat this case, Doctora? What you will do for her?
Investigations. Basic investigation.
Yes, what is the investigation you wanted to help the patient for?
Basic investigations, full blood count, differential, CRB, ESR, renal function panel, liver function panel, especially in this case because of the bleeding.
Why you will do all this case? Why you will do liver and the kidney and?
As basic investigations. I mean, patient with bleeding, like any kidney problem or liver problem, are at risk of bleeding. So at baseline, we need to check. Uremia,
This patient.
No uremia in the history, but I mean these are causes of bleeding. So I think as baseline, we have to do basic investigations, especially in a patient bleeding.
No bleeding. Water work, yes. Okay. Thank you, Doctora. Thank you.
Thank you.
How to manage this patient?
How to manage this case? Yes, Doctora.
Okay, disease education and counseling, multidisciplinary team approach, including rheumatologist, maybe orthopedic, physiotherapy, specialized staff nurse. Patient has to be careful with any, like, to avoid any major trauma. Maybe occupational health to look at the home for risk of falls and injuries. Specific management for the condition, really, I don't know. I don't remember.
No specific, only
There's no
symptomatic.
specific.
Okay.
Only symptomatic.
Mm-hmm.
Any
Thank you,
specific
Doctor.
precaution here, Dr. Ryan, for the patient? You want to counsel him?
I said about the driving because he's having the dizziness.
What else?
You already mentioned
What else? I'm not sure, Salah.
trauma.
Yeah, trauma.
Trauma. I
He
said.
has
Already you
hypermobile.
I think I said risk assessment management.
Yeah, but you have to specify it as avoid trauma, vigorous exercise.
Okay.
Okay, physiotherapy and social work. The job, did you ask about the job?
Yes, he told me something.
Secretary, right?
Secretary. Yes.
Okay, and how is he coping with the job? It's okay?
I asked the impact.
Okay. I guess any family screening here, do you think? إحنا Danlos? What the condition?
Autosomal dominant. So
yeah,
we need family
yeah.
screening.
Yeah, or at least genetic counselor to the team.
صح. Yes.
Perfect. Okay, let's go to the comment. Dr. Mahi, please start.
ما في كومنت كفايه عليا كده.
لا
That's enough for
لا.
me.
Okay, you were very kind, surrogate. MashaAllah. You give her the clue twice.
Yes.
I prefer Dr. I would, yeah, if you want to comment, you can start, Dr. Mahi.
No, but yes, at the end I try to give her some clues to reach the diagnosis.
I think this joint hypermobility, I will not ask it at all. Maybe I can ask you some joint pain, but this hypermobility, I will never remember it if you did not tell me.
Yes.
I
While
think
I'm
3
taking
times he gave you hint.
you did not give
Like
me
loose skin. Many
Yes.
times he
Yes. Many times he said. I was trying to link what could be, but
والله يا دكتورة ريان, you are very good يعني taking history. Yeah, because usually after 5 to 6 minutes you become irritable block, but you still taking history stable, no mental block for you, still asking, going down.
this is my big problem, yeah, Doctor. This is my big problem that I take history forever.
Yeah, and she exceeded the time of history and she didn't do examination.
Yeah. Because I am trying to reach, but I did not reach anyways.
It was, I guess, I believe, if you ask different than you are taller than your colleague, you can ask another question. I prefer to ask any skin change, any joint hypermobility, because he give you clue.
But I forgot this joint hypermobility,
so
honestly.
you will never forget it again.
Inshallah.
This
good case, very good
very
case,
nice
really.
very nice case, because he give you a clue that my skin different than our colleague. What do you think? Either HHT, right? Hereditary hemorrhagic telangiectasia, some rashes coming, or the skin itself looks different. He told you my skin is loose. Don't ask about Marfan. Yes, Marfan one of the possibility, but ask about the joint hypermobility, any change of any dislocation before, any trauma to your simple trauma, you have broken bone. It will give you a clue, either osteogenesis perfecta, this is for broken bones, or dislocation, Ehlers-Danlos syndrome. Okay, I prefer to ask this question rather than if you feel yourself taller than others, or yes, Marfan, you can ask about it, but ask other questions. Why you stopped here? He give you skin change. I prefer to ask in the system review about any joint pain or joint change or skin change or skin pigmentation. This is also one of the systemic review question I put in the video. It can give you a clue through the joint itself. And this case of joint disease, hypermobility, and dislocation and hypermobility.
Mhm.
Okay.
Yes. Yes.
I think the case was clear from all the topic, and Dr. Mohi also give you a lot of clues, and you got a very nice history taking. Every question was target apart from the part of joint and skin changes.
I think I asked very late because I was thinking
Yeah.
a bleeding disorder. So
Exactly. Yes, I feel that you are
Mhm.
taking history for the bleeding only. For honestly, to be honest, also I thought about von Willebrand disease initially when he said bleeding per gum, bleeding per uh, rectum, and coughing blood. But later on, I changed my mind to Ehlers-Danlos. It's a nice case again.
Because
Thank you. Yes.
أنا زيك برضو والله.
because I wrote BT and BTT are normal
Yes,
from the
von
start.
Willebrand will be normal, by the way.
BTT
Yes.
will be prolonged.
Platelet will be normal, yes.
No. It's bleeding time, not
Von
BTT.
brand platelet dysfunction, yes. Platelet
Yeah, so it will
dysfunction.
be normal BT and BTT.
Differential diagnosis.
Yeah, the differential will be
Differential
also.
diagnosis of easy bruising. Yes. Differential diagnosis of easy bruising, platelet disorder, either count or function, such as von Willebrand disease, ITP, TTP.
No, I think
like
we
this.
can put also
Vitamin
other
C.
hypermobility as a differential here. Ehlers-Danlos and stenosis imperfecta, right? By the way, Ehlers-Danlos has a lot of types, and it could be also differential every type.
Doctor, I
Yes.
was initially thinking of pseudoxanthoma elasticum, honestly. So why not? They also have elasticity. They have the same GI
Yeah,
hemorrhage.
it's the third differential for the two cases, Ehlers-Danlos and
But
stenosis imperfecta.
this is the last one, I think.
Pseudoxanthoma elasticum.
Chicken skin
Pseudoxanthoma
report.
elasticum. Hypermobility of the joints. Pseudoxanthoma elasticum.
Chicken skin, I
I
think.
think.
Babiola and legs.
Oh, yes. Pseudoxanthoma
I
elasticum joints are not hypermobile.
There
Buckhard
should be
skin, I think.
in
Yeah.
xanthoma elasticum, there will be visual problem.
there will be a what?
Retinoid
Vision?
Ah,
The vision
no,
problem?
visual problem. Yes, visual problem also. And in axilla or in the neck area, you can find pude orange
Chicken
skin,
skin, right?
Yeah, chicken-like
chicken
But
skin.
skin,
chicken
Yeah.
skin, I
chicken-like
think.
skin.
Yes, yes.
Ah,
Beleg and
yes.
babules. Beleg and babules.
Mhm. Okay. And
So,
so
so here the
this
investigation very important. Brighton criteria in this Ehlers-Danlos syndrome to assess the degree of joint hypermobility. Examiner may ask, is there any criteria for the joint hypermobility? It is Brighton criteria.
what is it?
Brighton
Can you
to
write it?
assess.
Can you write it, Dr.
Yes,
Azhar
I
or
will.
Dr. Mahiddi?
Yeah. Yes,
Okay.
I would like to. Brighton criteria to assess the degree of joint hypermobility. And there is a one specific sign, Gorlin sign. If you can you touch the tip of your tongue to your nose? Patient here can touch the tip of the tongue with his nose. Normally, we cannot touch our tip of the tongue to the nose. In this case, the patient can. This is sign Gorlin signs.
Very interesting. Please write it, Dr. Azhar. Huh?
Okay.
Thank
I'm
you.
very happy that you did not read the chat box because in the chat box I already wrote the diagnosis EDS, but you did not see the chat
No, I
box. I'm
didn't
very
know.
happy.
I thought it's pseudoxanthoma elasticum or something.
There, in pseudoxanthoma elasticum, there will be visual problem, and joints, stick, there will be in pseudoxanthoma elasticum.
Yes, usually
But
the
here,
first presentation for those pseudoxanthoma to the vision loss, gradual vision loss. And also she has bleeding, like in gut, especially in gut bleeding. But the skin, no ecchymosis, no any like that, no any joint problem or dislocation, no more elasticity, just it is like there is some character skin manifestation like bump skin in the axilla and in the neck especially. And it is coming also in exam. And Ehlers-Danlos also coming some centers have the
Yes,
cases.
yes.
Mhm.
Yes, yes.
Thank
Last
you.
time it came. This case came last time. Ehlers-Danlos syndrome. It came. An examiner asked,
Yes, and
what is the
pseudoxanthoma
criteria?
coming in Jordan also. In
Yes, you are right.
yeah.
You are right.
Thank
Yeah,
you, guys.
perfect.
Thank you
Yeah,
so much.
nice case and nice discussion. Thank you, Dr. Aisha and Dr. Razhar, Dr. Rashid. There is a lot of comments. I will try to read it. You have any question, Dr. Ryan and Dr. Al-Mahi?
Thank you very much for the case. It's a good case, Dr. Mahi.
Yes, always remember this unique cases. It will
Yeah.
never be forget. Because once you practice it, you'll never forget it. Now you have the hypermobile joint as a question whenever you feel the skin
Yes.
is different than others. Plus
Yes. Yes.
the bleeding itself. With
Really,
family
Mr.
history.
Bassett is very rare in our life, in these cases, but they making it like treasures. They keeping it for exam only.
Yeah, they love all the rare cases because
They,
no
you
no
will
one.
not face these cases in your life, maybe ever.
Yeah.
Yeah, there is
I
real
saw
cases
in
and
my
there is basis
hospital.
cases.
So one case. Really, I saw one case in my. I am not internal medicine. I am cardiologist, but I try to take this MRCP. My colleagues for internal medicine, Muhi, come, we will show you an interesting case. And I went typical as we see, loose skin, it make folding of the skin. يعني like obese person and he get lose weight much, so skin is very loose. You can take as you separate the skin from the down soft tissues. And this paper, cigarette paper burn scar, it is typical. I saw this patient also has some other problems in his life, and his skin was not good, not clean. Like, so I saw this case not rare, yani, so rare.
Very nice.
Yeah, again, we have real cases, either common or less common, but we have cases in bases. We have to know all cases of base. And I think we practice most of these cases in all sessions. What we practice is common in bases. But the real cases, of course, it will be different or not like we are facing in cases of bases. Okay, this is the
My
lesson.
colleague told me recently now MRCB changed. They give one acute case and one
Exactly.
chronic case.
Yes.
Yes, I
Yani,
agree for this. Yes. Yeah, they are trying to make you trained on the acute case how to manage and the chronic case how to manage.
Dr.
Exactly.
Yan, I send in the group. I send in the group about this Ehlers-Danlos syndrome.
Thank
You
you
will
so
only
much.
remember three things. SVJ, skin, V, vessel rupture, J, joint. SVJ, skin,
SVJ.
skin problem, vessel arterial rupture, J means joint problem, joint hypermobility. These three words you will remember for this Ehlers-Danlos syndrome. With trauma, there will be cigarette paper scar. There will be cigarette paper scar like skin. So I sent in the group. You can see it. Gorlin sign. I also sent the picture of Gorlin sign in the group.
Thank you so much.
Welcome.
Welcome. Thank you, Dr. Azhar. And let's try to read the comments quickly. I guess we missed the
What?
comment from
What
other
the?
scenario.
Just
Yeah,
question. What does the cigarette scar mean?
it's related to
It's just
the
that. Yeah,
Like the
Dr.
stretch
Matul, you
mark,
can.
healing, I
same
think
أنا يوم
as the
بيتعرض
stretch
لتروما
mark.
في
the
الحتة
healing.
دي
Yeah,
مثلا هو
healing
من
process.
yeah,
كتر مثلا هو
yeah.
Huh?
Because of the
I sent the
collagen.
picture of this.
Collagen.
Dr. Ryan, I sent the picture of all these cigarette paper scar. You can see. If
Thank
anybody
you.
touch
Thank you.
your skin with the cigarette, if anybody touch your skin with the cigarette, what will be the condition of the skin? I sent to you in the group.
Okay.
It's
Thank you, Dr. Azhar.
collagen defect, Dr. Ryan. So the healing
Mm-hmm.
will be
Yes.
different, scarring, like
Okay. Okay.
fibrotic,
Mm-hmm.
like burn
Mm-hmm.
because of defect in the collagen itself. Okay.
Okay.
Uh, anyone
Excuse me.
has comment? You can.
Excuse me. Salam alaikum.
Alaikum salam. Yes, Dr. Dalia.
I'm fine, thank you. Yeah, you are right. This is a common case in PACES exam, particularly in UK. So it could come with most probably this is will come with joint problem. And one of my colleagues has had this case in his exam, and the main complaint was ankle pain. So from the start, he asked if it increased by movement or by movement or rest. Yeah, improved by rest.
What is
So
pain? Pain where? Just
yeah,
And
ankle pain. So when you will
ankle.
analyze the pain, ankle pain, you saw there is not only two categories, that is inflammatory or mechanical. The third differential, usually for all joints, that is, yeah, just please put it in mind, it's joint hypermobility. So if it's neutral, it didn't change with movement or improve by rest, and said no change with move. It's okay, it's the same all the time. And there is joint problem that it's like twisted most of the time, and could be, when twisted there is pain or sprain, recurrent sprain, because it's grades of joint hypermobility. There is minor grades, then like up to the dislocation. So minor grades is just twisted, or sometimes with dislocation, but the patient could, yeah, it could come back itself. But again, sometimes its dislocation needs intervention. Okay, so it depends on the grades of the joint problem. So you could start the knee, ankle pain or something for, yeah, usually, but just remember that it could be joint hypermobility. Okay, and it's, yeah, they really need to know what's the differential, not the diagnosis. So yeah, just don't put yourself in just a tight diagnosis, because there is no marks for the diagnosis, there is marks for the differential diagnosis. So then the examiner will guide you to the one of them. Okay, yeah, be smart, don't put yourself in just one diagnosis, because there is overlap between them. So what you need to do for examination, because you yeah, in history and examination, so you just cover all the history side, but there is usually just offer the fundoscopy, because there is the if you don't have time, just offer that, and you would include that to refer the patient for fundoscopy, because you will see, and I saw it myself before, angioid streaks is really it's really characteristic to see angioid streaks. Okay, and the thing that I saw as well, that there is the skin changes in the neck, over the neck. Okay, I asked the patient to just pull her hair to a side to see her neck, and it's typical for the pseudoxanthoma elasticum. So it's just ask for the armpit, to examine the armpit and the back of the neck. Okay, and under the hairline. It's sometimes there is changes. There is no I can't how can I see explain that. It's like papules, same skin, but the texture is different. So this is different from scars of the any kind of trauma, easy traumatize the skin. So with recurrent trauma or something like that, it could heal by calcification. That's different. So, and just check for all patients with joint hypermobility, check the skin over the neck and axilla, armpit, and because the groin is not recommended. Okay, and flexural sides of the elbow, knees, you could see that. And there is three main categories for the Ehlers-Danlos, is to see the hyperextension of the elbow. If you ask the patient to extend their arms, then you will find that there is an angle degree degrees of the Angelis hyperextension, and for the knees as well. And ask the patient to put his hand like animals on the ground. I could send you the picture. It's 3 steps only. So to ask a patient to hyperextend the arms, to stand up for you, and you will see the angle is around 100 in the knee joint. It's more than 120. You see that hyperextended as well. And that's beside that the sum and the sum test and wrist test. Okay, this they usually done. So I could send you I will look for that and send it to you. Okay, so just a quick like that, and you could offer the fundoscopy. So you could say that, and usually patients the Ehlers-Danlos, there is great of the affection because maybe over 20 types or subtypes. Some of them have major disfiguring scars extended from the chest up to the abdomen. Okay, something really disfiguring, very big scars that for aortic dissection. So I guess this is a family history that he gave to the surrogate. He had one of his family died from the bleeding. So dissection, aortic dissection, and yes, they had aortic dissection. It could be from Marfan, it depends on how the vascular affection. So they are shared for that, and just I want to highlight these things for you from real patient, and thank you.
Thank you, Dr. Dalia, for clarification. And waiting for your image you promised. Share it to the WhatsApp group.
Thank you.
Okay. Thank you. Okay, the comment, I think, yeah, I will read the questions. There is good question here. Is the cases in the exam short? No, it's not short. It will be all the paper, paragraph here and there, the patient data, your task, your role. So you'll be confused what they are writing for me. And vital signs. Don't think they will give you a complaint of abdominal pain, address the concern. No, it's not. It's a paper, full paper written, okay? So don't think it will be like what we are practicing. But we are practicing on the target. But we have to learn how to read the paper, the paragraph, and to catch and to get the positive vital and the positive complaint and the patient name and the age, because you might be confused with the stress. You cannot read all these things. Please focus on the vitals. Sometimes the vitals give you a clue, like saturation 90. You have to go inside and to ask about any dyspnea and to offer oxygen. If blood pressure high, systolic is high, bradycardia, it might guide you to hypothyroidism. So this is the way how they are writing the case in the basis, in the exam, I mean. Okay, the other question I like also here, someone asked about hepatitis B or C cannot present acutely, Dr. Ahsan, and I don't think it will present as decompensated, but it will be acute on top, like decompensation after long time of presentation, hematemesis, melena, gynecomastia, and or chronic liver disease stigmata, strixis, jaundice, and tremors, all these things, and confusion, of course. Okay, fulminant hepatitis, maybe the differential, there is ascites. Fulminant hepatitis, yes, as after post-paracetamol, but it will be with positive drug history intake. Okay, I mentioned, yes, I answered this. Intravenous hemolysis only, Dr. Rashid, I guess so, but we will double check it again. Is BNH either intravascular or extravascular, but I remember intravascular. Acute
I
heart
also
failure,
remember
yes.
it was intravascular. Sorry.
Exactly.
I-
No, it's okay. Yes. Thank you for confirming.
Intravenous, I mean, intravenous only.
Yeah, the clotting itself. Yeah, you mean intra-arterial or intravenous?
Yes,
I think
yes.
everywhere, both arterial and venous. Okay.
Yeah, I'm not sure.
I'm not
It is
sure, but
venous.
Dr. Ahsan
mainly
also.
Venous. It is
venous,
venous.
hepatic vein.
Venous.
Yes, yes.
Yes, yes.
Likewise,
Both, I think, if it
likewise,
best arterial and venous, I think.
بهجت
Vincent.
arterial. Yes,
And
بهجت
venous.
arterial
Yes,
and venous, and antiphospholipid arterial and venous. But
yes, exactly. Yeah. Takayas
you
also
see,
arterial.
Dr. Bassam,
Yeah.
this case is PNH patient can also present with the problem with the vision. Cerebral, in this case, there will be cerebral venous thrombosis, cerebral vein thrombosis. There
Aha,
will be
okay.
cause of,
Yes.
if any patient comes with problem of the vision and
Yeah.
the underlying cause is PNH, in this case, it
Yeah.
will be cerebral venous thrombosis.
Yeah, any
Sorry, cerebral
thrombosis.
vein thrombosis, cerebral vein thrombosis.
You mean venous sinus thrombosis? Yes.
Yes, 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 yes.
Okay. Any thrombosis.
Dr. Basim, البات
Yes,
جهاد
doctor.
itself sometimes it can be acute, sometimes subacute like that. Not all time, always
Yes, but
sudden
it
like
will.
that.
Yeah, it will be rather than chronic. I mean, it's not chronic, right? Supposed to be acute or subacute, but it's not chronic one.
Yes, yes.
Okay, Dr. Ahsan. Yeah, Dr. Ahsan wrote also high dose vitamin C has role evidence, some evidence in treatment of Ehlers-Danlos. I don't think any of the examiner will remember this information. Just supportive treatment is the most important management here. In this case, will be spot diagnosis that can be reached from the look to the patient's skin of neck, arms, and hand. Dr. Phoebe, yeah, nice question. I think yes, if you notice the scars all over his skin, you will know this is different skin look. So please, whenever you find something different in the skin, examine the whole skin criteria and joint itself, mobility. Don't forget the wrist and thumb test. He can do some of different and weird movement by his body and joints. And of
And
course, you
I
have to ask about, yeah, go ahead.
yes, and better to have a look when patient mentions that he has skin changes during history. You can have a look and
Yeah,
better it can
yes,
help
you
you.
can, exactly, yes.
Uh,
And always ask about previous dislocation. It's a clue in this scenario. Okay. And I think Dr. Bohajers asked about does this case present in the exam? Yes, they brought it in Jordan, as Dr. Aisha said. It was uh, it was presented as, I think, a joint problem. I'm not sure, but they can bring such cases. And again, as I said, there is real cases and there is basis cases. Try to train on the basis cases and don't forget, of course, the real case. Okay, thank you. Yes, Dr. Dalia share the movements he can do. Oh, yes. I think these people will be talented and they can do this competition in the program. Really?
Marathon.
Yeah, they can do a lot of things which are very weird. Okay, Dr. Hatem, PNH, BASIT, APL, all are venous and arterial. Perfect. Thank you, Dr. Hatem. Thank you, Dr. Dalia, for the share. Thank you, Dr. Hatem, also for this information. I guess we reached to the end of session. It's very nice session. Thank you, Dr. Mahi. Very nice case, as well as Dr. Ryan. Very nice case and good performance. And Dr. Mohi, it's promising performance, I can say, because you are starting to practice with us frequently. It will give you a lot of confidence and it will be more organized with the time. Don't worry about that, okay?
very nice session. Thank you all.
Yes, thank you, everyone. Any question before ending the session? Thank you, Dr. Azhar, of course, is always with us, supporting us. Dr. Dalia as well. I hope I didn't forget anyone. See you tomorrow, inshallah, with the communication day. Dr. Dalia shared, I don't know what is this research for what, Dr. Dalia. Please, you can share it to the group. I will share it, okay?
Yeah, I will do. Yeah, that
Okay.
classification for the Ehlers-Danlos. I won't
Yeah,
bother with the details.
yeah.
Yeah, just
Yeah,
an
but I
idea.
don't think they ask for that. I remember 1 and 2 and 4.
Yeah, just general information. Yeah, don't bother
Yes.
to remind them. Thanks.
Yes. Okay. Thank you. See you tomorrow, inshallah, the communication day. Good luck on this. Assalamu alaikum wa rahmatullahi wa barakatuh.